Dr. Robin Lund is one of our pediatric emergency medicine physicians. She completed medical school at the University of Missouri-Columbia and then went on to pediatric residency at Children's Mercy Hospital in Kansas City. She recently completed her pediatric emergency medicine fellowship here at the University of Louisville and Norton Children's Hospital in 2021 before joining our medical staff. Academically, she enjoys training education, serving as both the pediatric emergency medicine rotation director and co-chair of the Pediatric Residency Clinical Competency Committee. Our second speaker is Tracy Van Horn, who is originally from Colorado Springs, Colorado, and did her pharmacy school training at the University of Colorado Skaggs School of Pharmacy. Tracy is a second-year resident in our critical care pharmacy resident and in or at Norton Children's Hospital. So we welcome both Tracy and Robin, and I'll turn it over to you guys to talk about common overdoses in pediatrics.
Thank you for that introduction, Dr. McDonald. Tracy and I are both very excited to be here, and hopefully you all can see my screen and hear me. So to begin with, Tracy and I have no financial disclosures. And to start off, we are going to break the ice with a nice, easy opener question. So to which Hogwarts house do you belong? And we have A, Hufflepuff, B, Gryffindor, C, Slytherin, D, Ravenclaw, and E, what's Hogwarts? Perfect. So we have a lot of Gryffindors, like over half, beautiful, some Slytherins, and some people that have no idea what Hogwarts even is. Awesome. Great. All right. So let's move on. So when talking about overdoses and poisons, it's important to remember that it's the dose that makes the poison, as aptly said by Paracelsus. Even water can be a poison if you drink enough of it, leading to hyponatremia and seizures. So here are our objectives for the day. So 1, recognizing those common pediatric drug overdoses, their applicable toxidrome and initial steps in management. 2, identify drugs that can be fatal to children in small or therapeutic adult doses. And 3, identify common substances used by adolescents and describe and prevent and address their use. So as we begin, how often do you think the U.S. Poison Control receives a phone call for an ingestion? Do you think it's every 5 seconds, every 15 seconds, every 1 minute, every 3 minutes, or every 7 minutes? And let's see what people think. So every 15 seconds, good. Every 5 seconds and every 1 minute. Okay. So let's see who's right. So ingestions are common. There's roughly about 2 million ingestions were called into poison control, human exposure ingestions were called into poison control in 2020. This equates, if you do the math, to about 1 ingestion every 15 seconds. So congratulations to the majority of you. Children make up the vast majority of those, and especially children under age 6. They account for about 38 exposures per 1,000 children. So like I said, we have this graph here that kind of shows in a different form of when exposures typically occur. So you have, as you go down, you have increasing age. And as you can tell, you have your exposures, and really from ages 1 to 3 and 4, there's quite a bit of exposure. So let's delve a little bit more into this discrepancy between young children and older children. So in toddlers and babies, it's normal and developmentally appropriate for them to put their hands and the environment into their mouth at any possible time. In fact, they try to do this about roughly 10 times an hour, which is a lot. As a result, they have single ingestions, they tend to be unintentional, and they tend to be exploratory in nature. Consequently, only about 1% of them end up having severe outcomes, meaning moderate, major, or fatal outcomes. Adolescent ingestions, on the other hand, are typically intentional, with about 30% being unintentional and the remainder being intentional. And consequently, as a result, the vast majority of these tend to have moderate, major, or even fatal outcomes. Let's look at this in another way. So on this graph, we have children on the left and adults on the right. We have blue referring to essentially non-toxic. We have red being no effect or minor effect, and then black is moderate, major, or fatal outcome. As you progress from children to adults, you can see that you have much more intentional ingestions, and you also have an uptick in ingestions that result in more harm to the patient. So what do you think is the most common single medication ingestion leading to pediatric fatalities? So we have antidepressants, diabetic medications, antihistamines, calcium channel blockers, melatonin, and analgesics. And I will say this is a single ingestion and it's a medication. And this is all taken from the poison control data of 2020. All right, so analgesics wins with 33%, antidepressants at 20%, diabetic medications, antihistamines, and then a few people said antihistamines. We have some calcium channel blockers and melatonin. Great, so we've got a great variety. So first, let's talk about what ingestions are the most common in kids, and then we'll talk about fatal ingestions. So these are your most common ingestions, and these include things like cosmetics, personal care products, cleaning substances, analgesics, foreign bodies, dietary supplements, vitamins, topical preparations, antihistamines, pesticides, and plants. And this is all taken from the 2020 National Poison Data System. So what about fatal ingestions? So your number one is actually, and this is from 2016 to 20, and this is in children under 6. The number one cause for poison control is fumes, gases, and vapors. And you might be thinking that's kind of weird. The number one agent was fumes, gases, and vapors. What's up with that? So what they're actually referring to is carbon monoxide. And I went through all the 2020 deaths of children under 6, and every single one of them was carbon monoxide, and one of them was carbon monoxide and cyanide. Aside from that, when you start looking at medications, the number one is going to be your analgesics, followed by an unknown medicine, cardiovascular drugs, then antihistamines, batteries, stimulants, alcohols, antidepressants, and chemicals. When you start including everyone, meaning your teens and your adolescents and adults, the substance categories with the largest number of deaths changes to include sedatives and sleeping medications, your opioids, alcohols, acetaminophen, stimulants, and street drugs. Over time, some of these subcategories have changed. So over the past 12 years, these are the medicines we're going to be talking about today. So we have analgesics, cardiovascular drugs, antihistamines, and then stimulants. So this shows substance categories with the greatest rate of exposure increase since January of 2010 for severe outcomes. So not necessarily just the greatest increase, but ones that have consequential impact on patients. And so you can tell the 4 that we have are antidepressants, antihistamines, alcohols, and analgesics. So now let's look at some deadly drugs, especially for pediatrics. So these drugs, as a list of medications that can be fatal with even a single dose, earning them the moniker "one pill can kill." These include calcium channel blockers, tricyclic antidepressants, opioids, salicylates, toxic alcohols, sulfonylureas, camphor, clonidine, and antimalarials. And today we're going to be talking about some of these, including calcium channel blockers, opioids, salicylates, and also clonidine. And at this point, we're going to talk a little bit about ingestion basics. So as a reminder, for all ingestions, it's really important to get a good history, including what was taken, when was it taken, how much, whose medicine is it, how certain we are of these things, and what was their intent. On physical exam, we can try to look for a toxidrome by including symptoms, vitals, and physical exam findings. As we delve into some common ingestions, here's an agenda of the drugs we'll be covering. So we have acetaminophen, salicylates, diphenhydramine, calcium channel blockers, beta blockers, clonidine, methylphenidate, and opioids. And now I'm going to turn over to Tracy to get us started.
Thanks, Robin. So yes, first starting out with acetaminophen. This is a very commonly used medication that's both an analgesic and an antipyretic. It's available over the counter in a lot of different formulations like liquid, tablet, suppository, as well as a lot of combination cold and flu preparations. So that's really important to be aware of and watch out for. Acetaminophen, if you look on this graph on the right, it's metabolized by the liver in 3 different ways. So the majority, about 90% of it, either undergoes glucuronidation and sulfation. And so this creates non-toxic metabolites. But then about 10 to 15% undergoes metabolism through the cytochrome P450 system into this reactive toxic metabolite called NAPQ. And so normally an enzyme called glutathione will further break this toxic metabolite down to a non-toxic one to then be eliminated. But then when you have an overdose, both the glucuronidation and the sulfation pathways become saturated, and then the majority of the metabolism will then have to go through that P450 pathway and create that NAPQ metabolite. And so you start having a buildup of this toxic metabolite, which then can lead to liver injury and necrosis. There are a lot of different types of acetaminophen ingestion. So the basic one we always think of is acute, which is when you have an overdose that occurs with a single ingestion, usually within an 8-hour period. But then there's also this repeated supratherapeutic ingestion, which is where you have multiple ingestions that end up leading to an overdose. And usually these ingestions occur over a time frame that's greater than 8 hours. So acute is a little bit easier to manage since there's a lot less variables involved. Acetaminophen overdose does involve 4 different stages. So that first stage occurs within 24 hours. Usually there is no hepatic injury yet, and patients can be asymptomatic. But if they do have symptoms, then they can show some GI distress, malaise, and some sweating. And then that second stage occurs between 24 and 36 hours, and that's really where you'll start seeing this hepatic injury and an increase in your liver enzymes. The AST is really what we want to watch out for more because it's more sensitive compared to the ALT, and that will rise early on, and then it will also decrease at a quicker rate compared to your ALT. So that's good for detecting early hepatotoxicity and recovery. And then stage 3 is between 72 hours and 96 hours. And this is where you'll have your maximum hepatic injury, and you will see those liver enzymes super elevated. Usually the patient will start having symptoms like encephalopathy and a coma. And if they were to have death, it would occur during this stage. And then finally, that stage 4 is the recovery phase, where you start having some hepatic regeneration, or they might have to go for a liver transplant. And then your LFTs and creatinine and other lab values can take weeks to even months to normalize. So really the question is, how do we know if acetaminophen ingestion is toxic? Well, it's important to really remember that you want to try to obtain an acetaminophen level 4 hours after ingestion. If the time is unknown, then you want to try to use the earliest possible time just to be more sensitive. If you get a level that's obtained before the 4 hours, it's really only helpful if it is negative, just to rule out the ingestion. But if it's positive or elevated at all, then you want to make sure you get that 4-hour level. So then we can plot it on this Rumack-Matthew nomogram, which is here on the right-hand side. So this nomogram on the y-axis is the acetaminophen concentration, and on the x-axis is the hours post-ingestion. So there's 2 lines that you can see. The dotted line, this is the Rumack-Matthew line, and this is what the scientists, when they first discovered this, had determined where that toxic concentration, where you start having like hepatic toxicity and all of that occur. So the solid line is actually what the FDA had put in place, which is a 25% reduction from that Rumack-Matthew line, just to be more conservative. And that's what we now consider our treatment line. So if that level were to be plotted anywhere past that treatment line, then we want to treat for acetaminophen toxicity, which we use N-acetylcysteine, which I'll go to in a little bit. But as you can see, if you look at that graph, at 4 hours on the x-axis, it equates to 150 mics per ml. So it's really good to just know the rule of 150, because not only is that the acetaminophen level at 4 hours that needs treatment, but also 150 mics per kg is also considered the toxic dose of acetaminophen. This is just specifically for acute ingestions. Chronic or staggered ingestions can become a lot more challenging. So if there are symptoms at all in chronic ingestions, then you want to treat. If they are asymptomatic, then you're going to have to consider how much have they been receiving, how frequently, for how long. And you can also look at lab values like the acetaminophen level and your liver enzymes to try to determine if you need to treat. So looking at N-acetylcysteine, so this is the antidote that's used to treat acetaminophen overdose if it does cross that treatment line in that Rumeck-Matthew nomogram. It works by restoring the glutathione stores that are in your liver to detoxify that NAPK metabolite. So this will just prevent any further damage from occurring, but it doesn't actually reverse hepatotoxicity that's already present. Here in Kentucky, we do recommend using the 3-bag IV therapy. So this is 150 mg per kg over the first hour, 50 mg per kg over the next 4 hours, and then 100 mg per kg over 16 hours for a total of 21 hours treatment. There is an option to do oral treatment, which is over 72 hours. It's not usually recommended just because it's really not well tolerated. It doesn't taste great and it actually smells like rotten eggs. And again, it's over 72 hours, so not an ideal time frame. The biggest side effects, nausea, vomiting, that's more so with the oral N-acetylcysteine, but it has been reported with some of the IV formulation. But the big one is the anaphylactoid reactions, which usually those are seen within that first hour when you're doing it at that higher dose. And then usually we'll continue this therapy. They may need another 100 mg per kg, 16-hour bag until their LFTs are less than 3 times the upper normal limit. Next slide. All right, so next is salicylates. The most common one that we think of medication-wise is aspirin, which this also can come in combination products, and it's available over the counter. But there's also some other over-the-counter agents that we don't typically think of, like oil of wintergreen and bismuth subsalicylate, which is also known as Pepto-Bismol. These agents work by inhibiting the cyclooxygenase, which inhibits prostaglandin synthesis, and then that can inhibit platelet aggregation, and it also has some antipyretic, analgesic, and anti-inflammatory properties. They are usually rapidly absorbed, but some products can be enteric-coated or delayed release, so that will affect the absorption time. And so it's important to make sure we're getting serial salicylate levels every 2 hours due to just the variable absorption, and it might not peak until 12 hours post-ingestion. The usual toxic dose, again, is also 150 mg per kg. So for the toxidrome, usually early on in the ingestion, symptoms are more so like GI distress, headache, dizziness, tinnitus. Usually all these can be seen within a couple of hours. And then as that salicylate level starts to increase, then the patient can start having more neurological symptoms like confusion and hallucinations. And then you also get stimulation of the respiratory center, which leads to hyperventilation and respiratory alkalosis. Toxic concentrations can also impair the renal hemodynamics, and it does this uncoupling of oxidative phosphorylation, which leads to accumulation of pyruvic and lactic acids. And then there can also be a generation of ketones. So all of this can lead to a anion gap metabolic acidosis. So then you have a mixed picture with the metabolic acidosis with respiratory alkalosis. And then when the symptoms get really severe, usually that's when levels are over 100 milligrams per deciliter, then you can start having pulmonary and cerebral edema, and then eventually that respiratory alkalosis will actually change to respiratory acidosis. So it seems a little bit confusing with all the symptoms, but again, it's just based on how severe the ingestion is, like a lot of these medications. What is really interesting, this oil of wintergreen, it's an essential oil that's usually used to treat myalgias. The active ingredient in it is actually methyl salicylate. And so what is an interesting statistic is 1 teaspoon or 5 milliliters has 7,000 milligrams of aspirin in it, which that's equivalent to 90 baby aspirins, the 81 milligrams. If you look at just take 1 milliliter, for example, that has about 1,400 milligrams of aspirin. So if you think about we said the toxic dose was 150 mg per kg. So in just a 10 kilo patient, all they have to do is take 1 ml and they are at very high levels of salicylate, which can be very toxic. So to manage salicylate overdose, it's mostly supportive care, like a lot of our medication overdoses we see. You can use activated charcoal. It might be helpful, especially if they're enteric coated or delayed release products. But the mainstay really is to alkalize the serum, which can be monitored by your urinary pH. So alkalization actually reduces the fraction of salicylate in the non-ionized form. And so that will increase the pH gradient in the CSF and prevent entry and remove the salicylate from your CNS. So to try to decrease all of those symptoms. You really want to target a urine pH of greater than 7.5. And we do this by giving IV sodium bicarbonate. Usually we'll give a bolus dose and then follow it by an infusion at like 1.5 to 2 times maintenance. And then if there's any hypokalemia, we also want to try to correct that to optimize the alkalization. And then dialysis is an option if we do have those severe salicylate levels that are greater than 100 and you're starting to have that pulmonary edema, cerebral edema, or even if you just have really bad acid-base electrolyte derangements, dialysis can really help that. All right, so moving on to antihistamines. This is another really common ingestion. In particular, diphenhydramine, I feel like is what we would see a lot. This is your first generation antihistamine, and it competes against histamine to bind to those H1 receptors on the effector cells in the respiratory tract, the blood vessels, GI tract, and the CNS. What's also important, and some people don't always realize, is they inhibit muscarinic, alpha, serotonin, sodium, and potassium channels. So that's where a lot of these side effects come from, and especially in overdoses. Diphenhydramine is really well absorbed and it usually reaches its peak concentration within a couple of hours. And then the max antihistamine effect usually occurs a couple hours after that peak. So usually they'll present with anticholinergic effects and CNS depression. You all might have heard of mad as a hatter, blind as a bat, red as a beet, hot as a hair, dry as a bone. This is just to describe those anticholinergic side effects. And management, a lot of times, is really just supportive care. We, again, can consider activated charcoal, but it might not be as effective as some of our other medications since it does have really quick absorption. Then we can give IV fluids and vasopressors if they're hypotensive. If they're having bad agitation or seizures, we can give benzodiazepines. Sodium bicarb can be used to reverse any conduction abnormalities. And then physostigmine, we don't use a lot. And there's a lot of exceptions that we probably won't end up using this, but if it's a known antihistamine ingestion and there's no cardiac abnormalities or pulmonary disease, then you could consider it. And then refractory last line usually is intralipid emulsions and VA ECMO if we have to. So then now moving on to calcium channel blockers. This is also becoming more frequent in ingestions that we are seeing. These medications inhibit the opening of the voltage-gated calcium channels in the myocardial cells, smooth muscle cells, and the beta cells of the pancreas. And they can be categorized into 2 different groups. You have the dihydropyridines, which these work directly on the vascular smooth muscle to produce peripheral arterial vasodilation, which then can decrease your peripheral vascular resistance and blood pressure. So that works more so on those smooth muscle cells. And for example, those are any of the drugs that end in penes, like amlodipine, nifedipine, isradipine, all of those. And then you have the non-dihydropyridines, which those work more on the myocardial cells to decrease cardiac conduction and contractility. And so those are your diltiazem and verapamil. Common symptoms, I guess I should back up and say in an overdose, a lot of times the selectivity of both of these for these particular cells gets decreased. So you can see the effects on both the smooth muscle cells and the myocardial cells for either category. Some common symptoms include, the most common is hypotension. You can see bradycardia. Again, typically these are with the non-dihydropyridines, but you could see them with dihydropyridines in an overdose. And you can have bradydysrhythmias, and then hyperglycemia is another one that you can see just because of the inhibition of those beta cells on the pancreas. What is another thing to take into consideration is the half-life of these medications. A good example is amlodipine. The half-life for that one is like 30 to 50 hours. And so since it's really long, you can see symptom onset later, and then these symptoms can last longer. So you always want to take into consideration those half-lives. For management, we again can try and do the activated charcoal if they are a candidate for it. And then really, again, supportive care. Fluids, I write this here because usually we recommend to do smaller boluses, about 5 to 10 mg per kg, just because we don't want to overload the patient if they are already having myocardial depression. But again, hypotension is an issue. So if they can tolerate the higher boluses, great. We might have to use vasopressors as well. And then IV calcium is going to want to be considered and given. Typically, our calcium chloride is preferred over calcium gluconate, and that's just because it can rapidly increase that ionized calcium quicker. However, the caveat is calcium chloride has to be given through a central line. And so a lot of times, especially if they present and they come into the ED, they're not going to have a central line, so then we'll have to give calcium gluconate. There's also this hyperinsulinemic euglycemic therapy. This is becoming a lot more popular, and there's a lot more evidence for it coming out. So it's becoming more of an upfront option in these overdoses. And this is where they are given a bolus of high-dose insulin that overcomes these calcium channel blocker induced hypoinsulinemia and insulin resistance, to then help improve that hyperglycemia state that they're in and improve the uptake of the glucose into the myocardial cells. And then they'll follow it. It's called euglycemic because then you'll follow it with dextrose infusion, so you don't cause them to become hypoglycemic after that. And then refractory options are lipid emulsion, pacemaker, if need be, and VA ECMO. The other important, I'm a pharmacist, so I'm always thinking about pharmacokinetics. They do have large volumes of distribution and high protein binding. So that makes this, you can't use dialysis for these medications. You're unlikely to remove them from the blood just since they have that high volume of distribution. And then next, we're going to go into beta blockers. These medications inhibit the beta receptors, which reduce the production of your cAMP, which then can lead to decreased amounts of calcium intracellularly. And that helps, that will cause that myocardial contraction. And so the toxidrome that we typically see with this, big symptoms are just bradycardia and hypotension. What's different is this can cause hypoglycemia, which is different from calcium channel blockers that cause hyperglycemia. And then hyperkalemia and CNS depression can also occur. Each beta blocker is a little bit different on the receptors that it acts on, but kind of like how I talked about earlier, in an overdose, that selectivity usually gets lost. But it is important, I think, to know that sotalol, although we don't use that very often, but that is a potassium channel blocker as well. So that can cause QTc prolongation. And then propranolol has some sodium channel blockade. So then that can decrease cardiac conduction and contractility, which can lead to some tachyarrhythmias. And as you can see by my pharmacokinetics graph I have here, there are a lot of different properties. Really, all I wanted you all to get out of this is the half-lives are different, the lipid solubility. Since all of that is different, this just might affect the types of symptoms you see in these overdoses and how long the symptoms can last. And then treatment is really similar to how how I just talked about with calcium channel blockers, really supportive care, activated charcoal, fluids, vasopressors. Really, you just treat the symptoms that they are having. And then glucagon is added to this list since it can cause that hypoglycemia. And then I'll pass it back off to Robin to finish a couple of medications.
So the next one is clonidine, which is a member of the imidazoline family, which also includes like oxymetazoline and also tetrahydrozoline, which are better known as Afrin and Visine respectively. This is a central alpha-2 agonist, and so it stimulates the alpha-2 receptors, which will decrease your sympathetic outflow, which ultimately decreases your norepinephrine concentration. There is one thing to say, in overdoses, you can get a transient hypertension prior to getting hypotension. And the reason for that is twofold. Is one, you have stimulation of your alpha-1 receptors in the periphery, and then you also are going to have some increased nitric oxide production. So in an overdose, you can get a little bit of hypertension prior to hypotension. The toxidrome is very similar to what we're going to see for opioids. So you're going to get bradycardia, hypotension, like we talked about, meiosis, lethargy, hypothermia, very altered mental status, respiratory depression, and coma. And this is a nice little graph. I think one of the things that's really important to realize is a lot of these come in very lethargic or with a coma. And so the right-hand side of this is these are just 33,000 kids that they looked at, and almost 90% of them came in with lethargy or coma. So that's a pretty reliable finding. And so as you might guess, this looks very similar to an opioid toxidrome. So the treatment tends to be similar to how we treat opioids as well. So we can do activated charcoal, which is what the AC stands for, but you can also do naloxone. I will say this doesn't always work. It works in about 16% of cases. And the way it works is by reversing the beta endorphins that are released by the clonidine overdose. However, you have to give significantly larger doses than you would for a typical opioid ingestion. And so in terms of like dosing, the evidence is kind of controversial on what type of dose you should be using, but it needs to be larger than what you use for typical opioid ingestion. In terms of other symptoms, is if you need to protect their airway, you're going to have to intubate them. For sinus bradycardia, they do respond to atropine. And then for hypotension, we give fluids and ionotropes. And these kids tend to present pretty quickly. So usually they come in within 30 to 90 minutes with symptoms, and it can last up to 3 days with symptoms as well. On the flip side, methylphenidate, because we're seeing kind of an uptake in this as well. So the way it works is it blocks your dopamine and your norepinephrine transporters. So it leads to an increase in your synaptic dopamine and norepinephrine. So as a result, as you might expect, when you have increased norepi, you're going to have a sympathomimetic toxidrome, which includes mydriasis. You're going to have agitation, tremor, delirium. You can have hallucination. They get hyperreflexic, seizures, tachycardia, and hypertension. The vast majority of these ingestions tend to have moderate severity. However, there are a few fatalities out there. And so looking at the 2020 data, there were about 5,800 ingestions of single agent methylphenidate ingestions. Of those, there were no fatalities. There were 22 with major effects, 645 with moderate effects, and 850 with minor effects, and 1,400 had no effects whatsoever. The treatment for the management for this is going to be your benzodiazepines. And this is used one for seizures, but also for the hypertension, the tachycardia, for pretty much the agitation that they have is you're going to use your benzodiazepines. And you want to start low and go slow and gradually titrate up to what you need for the patient. For opioids, we're going to talk a little bit about the most common opioid that we typically see is hydrocodone and acetaminophen. And the way it works is by stimulating the opioid receptors. And there's tons of different classes of opioids out there. And some of them stimulate, there's 4 different types of opioid receptors. Some of them stimulate various receptors, some are antagonists. It really just depends on which opioid you're talking about. The toxidrome is pretty well known to most of us, but kind of reiterate, you get CNS depression, meiosis, so the pinpoint pupils, respiratory depression, which is the problem that causes for most of these people, hypotension, bradycardia, and hypothermia. And deaths are typically from respiratory depression and or hypoxia. So there is an antidote for opioids, which is naloxone. It is a competitive opioid antagonist. And there is dosing on this. And so the IV dosing is 0.1 milligrams per kilogram up to 2 milligrams per dose. And you can repeat that every few minutes. You also, if you don't have an IV, you can do intranasal. And there comes a naloxone kit that you can get, which is 4 milligrams intranasal as well. And this is one of the medicines that you can administer pretty much any way you can get access. So IO, so in the bone, IM in the muscle, through the AT tube, or sub-Q as well. The adverse effects are pretty minimal. You can get some withdrawal, especially in people that are on chronic opioids, but otherwise it's going to be agitation, nausea and vomiting, and then also some body aches. So typically when I give this, I usually have a puke bag with me just in case, but that doesn't always happen. So a little summary slide here. So I try to make this a little bit interesting. So this is the emojis for toxidromes. And so we have the first one we talked about was anticholinergic. And so we're going to have an increase in our heart rate and our blood pressure. Temperature goes up. There's no change in our respiratory rate. You usually have mydriasis, and they're usually pretty dry, right? That's that hot as a mad as a hatter, red as a beet, hot as a hare. Cholinergic, you have no change in your vitals, but you will have meiosis, and they can be pretty sweat and wet as well. Opioids, everything's kind of turned down. So all your vital signs are down. You're cold, you have meiosis, and they're also dry. There's no sweating. And then sympathomimetic, everything's revved up, and you have your pupils are going to be dilated, and you're also going to be sweaty as well. And then there's some examples on the right-hand side as well. So I'm going to talk a little bit about substance use in adolescents. So the big three that we see in teenagers is alcohol, tobacco, and cannabis. And I want to bring up, this is a lot of this information is from Pediatrics a couple of years ago. Confidentiality is a really important thing to discuss with teenagers. And I think it's also really important to know that it's not just the confidentiality that you have with the teenager, but also realizing what insurance is going to be giving the family. So EOBs, or explanation of benefits, can have information on there that you might not realize is being disclosed to the patient. So it's really important to have a very upright and forthcoming conversation with the adolescent. And then the biggest thing is just asking. A lot of these teenagers, if they're ready to talk about it, they will talk about it. It's not as easy to identify substance use in teenagers as it is in adults that typically might have track marks or other types of physical stigmata. It's a little bit harder in teenagers. So really the recommendation by the American Academy of Pediatrics is to ask. There are several validated tools. HEADS is one, Shades is another, Craft. And there's tons of them out there that you can use. And then the AAP recommends doing SBIRT, which is screening, brief intervention, and then or referral to treatment if needed. And so based on the results of, like when you're asking a patient what's going on and what their drug use is, if they're abstinent, you really want to focus on positive reinforcement. So that's great. I'm really positive. I'm really glad that you're not doing drugs. And then you want to give normative responses to the questions. So when you're asking about these drugs, you're going to say things like, yeah, like many kids your age, they don't try alcohol either. So it makes it seem like you're not just asking them because there's a reason you're asking them. If they have substance use without a disorder, generally you want to give like a simple statement of this is why we don't like this. This is why I would not recommend it for you. And then when you start getting into your mild and moderate substance use, they recommend giving basically motivational interviewing. Try to figure out a way to negotiate their change. And then if it's a severe substance use, they recommend referring to treatment. And this could include some of the options that we're going to talk about in just a minute. So for people that are within the Norton system, there is a DOT phrase that you can steal from me. It's DOT resource substance abuse. And this just goes over some of the resources that we have for people within the Louisville and Kentucky area. So these are we have private counseling. There's both intensive outpatient treatment and then also residential treatment. And then I think it's really important that it's not just the patients themselves, but their family members are also very affected by addiction. And so there's groups out there that help family members as well. And all of this is found on that DOT phrase as well. And now I'm going to turn over to Tracy so she can talk a little bit about naloxone over the counter.
Yeah, so as we had talked about earlier, naloxone can be used in opioid overdose. We really want to encourage anyone to have naloxone nasal spray at home if there is just any chance, any possible way that an overdose could potentially happen. So usually if they're teens at high risk or parents are on chronic opioids at home that a child could potentially get into, it's just really important to have that naloxone at home just because we know it can definitely save some lives. There is this first bullet, the Kentucky Office of Drug Control Policy. This actually is a website that shares the locations of pharmacies that can dispense naloxone without a prescription. So here in Kentucky, there are a ton of different pharmacies that will give out naloxone. A lot of times insurance could cover it, but if they don't, it is a little bit expensive. We do have it available here at our outpatient pharmacy at Norton. And then we also have this awesome program through our ED where we're able to give out free naloxone kits to any patient that we think is at high risk. And so that's another great resource that we are able to take advantage here at Norton Children's. The second bullet, the next distro, this is a website I found that if the patient is or the family is uninsured or they're not able to access naloxone locally, you can, I think, apply on here and they will hopefully, if you qualify, I'm not sure the qualification specifically, but they can mail you a free naloxone kit. And then the Kentucky Harm Reduction Coalition, they have a great website with a lot of different resources, not even just on opioid overdose and naloxone, but a lot of different overdoses. So that's another great resource. And with that, I think that is all that we have for you today. What questions do you have for me or Dr. Lund?
Thanks, guys. So are you guys seeing bath salts being ingested by adolescents now?
I personally have not seen a lot of those. No, I would say we're seeing an uptake, excuse me, in cannabis, like dab pens and things like that, but not really bath salts. No, I haven't.
And then are you seeing some of that laced with fentanyl?
I've heard that. I haven't seen that personally, but that's the word that's what I've been hearing. Yeah.
And so why is that? So if you were a drug dealer, and why would you use expensive fentanyl and lace your heroin or your cannabis?
I think that's a great question. I honestly think it's just because you only need a little bit to get an effect from it. So I think I don't know why, if you were a drug dealer, why you would do that, but I get if you were a user, why you might want it. But I'm not positive on that.
All right, I can never figure that out. I'm dying to know that answer. So let's see, what things can you look for to diagnose chronic acetaminophen ingestions?
Yeah, so kind of like I talked about, it's very hard to be able to, I guess, distinguish and figure out if they are having a chronic ingestion. The biggest things just look out for if like hepatotoxicity, if they are having any GI upset, if they, you can always get labs outpatient. If they are, I guess, just having, if it's further yellowing of the skin, they could be bleeding or bruising easier if they aren't producing those coagulation factors. But I think the biggest thing is really just to try to get a history on if they've been taking anything. And if you're having any concerns at all symptom-wise, you're going to have to refer them to the ED and they'll probably need treatment right away. But chronic, yeah, is definitely hard to diagnose.
All right. And so are you guys using the nasal spray in the emergency room? Naloxone nasal spray?
We typically, not for patients, typically we usually get IV access.
Okay.
But theoretically, if you couldn't get IV access, we could. But most of the time I've gotten IV access. And then they're getting the kits.
And then all the kits have nasal spray?
Correct.
The
Okay.
kits have nasal spray, yeah. We will use, so you can use the IV formulation intranasally, which is normally what we would do. We don't actually use the intranasal formulation. We'll just use the IV to give intranasal if need be.
And then, for younger kids, do they have to dose the nasal spray in those kits, or can they just give the whole dose?
Yeah, that's a good question. So we'll just recommend to give that whole intranasal dose just because it only comes in that 4 milligrams. And like Dr. Lund had said, there's really not a lot of side effects to naloxone. The biggest thing, the only thing to maybe consider if you could avoid neonates, it might not be ideal because of absorption and everything, but you can still give it. If you have a different way to give it, that's more ideal. But yeah, you would just give the full dose.
And then is it similar to the IV dose in that, its half-life is much shorter than a lot of these narcotics? So, you have to get these people to the hospital.
Yeah, exactly. A lot of times they might need repeat doses. So if they don't have that available to them, usually in those kits, it does come with 2. So especially like you're saying, some of these that are laced with fentanyl or different things like that, it might not be enough to be able to reverse. And usually with the naloxone, what we're trying to do is just prevent just to like wake them up a little bit and let them have that respiratory drive on their own, not necessarily completely reverse them. So, but since it has a shorter half-life, then we want to make sure to get them to where they need to be as soon as possible.
Okay.